Hey, welcome back, everybody. It's time once again for another show about health here on Health Talks with Dr. Trinh, the one man who knows how to tie it all together, maybe even integrate health systems. Is that what we're talking about here today, Dr. Trinh?
Yes, we are. Yes, we are. Welcome, guys, for another Thursday Health Talks. And I am excited to bring, I should say, Professor Avram Kaplan on up at UCLA.
And can you hear me?
Yes, we can.
Okay.
And his and I like your background there.
It's like the City of Hope Hospital or whatever that is.
Well, that's the USNS Mercy Hospital ship.
Yes.
Okay.
Which I had the privilege of touring about 2 months ago. And Dr. Trinh and I and his family had the privilege of me giving a tour of the USS Midway.
Yes.
I'm a docent on the Midway.
Oh, my goodness.
And it had Captain Quast, the captain of the Mercy, Dr. Trinh and his family, Captain Quast's family, and a very special guest as well. And that's a whole nother story.
We got to talk offline because I would love to see the Midway. I don't know why I'm a big World War II buff. My dad was a bomber pilot. Yeah.
Paul should be part of our part 2 tour.
Yes.
Of that Midway.
Oh, I would love to. I've always wanted to go see the Midway down in San Diego down there. Absolutely.
Oh, well, it's my pleasure. I do give private tours at no cost because I love doing it. And we could always organize that.
We should definitely do that. And where was the hospital ship? Was that in the same San Diego Bay as?
Yeah, the hospital ship is home ported in the 32nd Street docks, the Naval Yard in San Diego below Coronado Bridge.
You know, I don't think people have a full understanding of all that's down there. I know they realize that that's one of the, I forgot which fleet, but it's their home port. And so there's a lot of aircraft carriers and other things down there and stuff. But I don't think we fully appreciate all that's there in San Diego.
I could give a whole another radio show on that.
I'd love to. I'd love to, because I think we just sort of take it for granted that the Navy's down there, but we don't really know much about what's there and all that's the capabilities and the crews that are down there. All right, so good. All right, well, that's a whole nother show. Today, though, you're talking about a course that you teach way up at UCLA.
Correct.
On what?
Well, I teach a course called Integrated Health Systems. And let me give the context of the course.
Okay.
I'm a lecturer at the Fielding School of Public Health, UCLA.
Okay.
We're one of the larger public health schools in the nation. And I teach in what's called the Executive Masters of Public Health Program.
Okay. That's a mouthful. Break that down. The Executive Masters of Public Health.
Executive Masters of Public Health Program is a 2-year in-person degree where people who are working in the field, such as Dr. Trinh, for instance, if he wanted to earn a master's in public health and health administration. My class coming up, I have at least 3 physicians, a number of physician assistants, nurses, lawyers, and administrators. These are all working folks who take these courses in the evening and weekends. I happen to teach this Saturday is my first session. It's 4 hours for 7 sessions. And there are 3 quarters and there's 2 years of that. So it's people who are working in the field who want to advance in their field into administration.
Ah, okay. So I was trying to get at what's the purpose of the course? You want to get into administering healthcare systems?
For instance, we also have a day program, the Standard Masters of Public Health, where our students who are not working go right in there during the day and are taking the courses. This is, in essence, the same course, but for working individuals.
Can I ask a really dumb question? I specialize in dumb questions here. That's my.
There are no dumb questions, and that's the first thing I say to my students.
I have a PhD in asking dumb questions. All right, so many years ago, they changed used to be School of Nursing, and there are doctors. And all of a sudden, we merged this all into this amorphous public health. And we always talk about public health. And I don't know really what public health is. Is public health just hospitals? Is public health insurance providers? Is what is public health? What is the School of Public Health? What is this field of public health?
Well, let me say this, that we still have, of course, schools of nursing, dentistry, medicine, veterinary,
right.
And we have School of Public Health. And you have to go back into the history of healthcare in this country.
Right.
Where, in fact, the first organized delivery of healthcare took place in the Marine Health Service back in the 1880s, where, lo and behold, people coming into ports were sick.
Yeah.
They were importing diseases.
Yeah.
And so the Marine Health Service, which was the precursor to the public health service of the country, focused on preventing disease. Prevention, that's the key word here. That's really the key word for public health. And then went on from there to the public health service, National Institutes of Health, public health departments. Public health departments grew locally. Because all medical care is local. And so the counties and the states took over the delivery or the functions of public health. And then we saw from there the growth of county health services from the county poor farms in the county, and then some private hospitals. And it wasn't so hospital centric back in the early 1900s. Medicine was still growing and in some ways didn't have all the tools. And medical care was delivered by the physicians at home or in their office. And it wasn't as big a business as it is now.
No, that's for sure.
Wow. Look at it that way.
And so is public health really the governmental arm of ensuring, vaccinations and programs?
Keep public health separate from national health insurance and from providers and organized health systems and methods of reimbursement. The classic public health department is what you hear about, and public health became important during the time of this infectious disease called COVID.
Yeah,
right. Public health has always focused on a number of arenas, in particular infectious disease, sanitation.
So trying to promote the public's health by principally preventing or catching infectious diseases originally as they came in from boatloads of immigrants or as they came in from visitors from other countries. They're importing diseases. We got to catch these and prevent them. And later on, it became kind of this policy of immunization for polio and other sorts of diseases.
That came along, and that's one way of primary prevention is the inoculation and vaccination. Again, the focus public health as defined separately from medical care.
Right.
You would say public health can say that they prevented more loss of life than medical care.
And where is public health centered? Is it local, like there are county public health care officers?
Yes.
Is it state public health care? Are there federal public health care? I don't know who's involved.
There's all of that. There's all of that. But primarily the history is that it developed locally in counties and state, and every county has a public health department that has looks at sanitation, water quality, infectious disease and monitoring. They may have clinics, may or may not.
Right.
They will put up vaccination clinics.
So let me ask the hard question, and then we'll get to the better stuff here, the gooder stuff. The hard question is, before COVID, or as COVID hit, we read over and over and over again that local public health had not been a priority and was underfunded. So when they suddenly had to Oh my goodness, we got to decide, are we going to shut things down? Are we going to set up vaccination clinics? How are we going to monitor? Oh, all of a sudden it's popping up everywhere. How are we even going to monitor this? They weren't prepared for this. They didn't have the funds, the people. Is that true?
All the money in the country is focused on cure and then chronic disease and acute disease. That's where the money goes, because the immediate need is in front of your face.
Right.
From having a heart attack, get in an ambulance, rush you to the emergency department, go to the ICU, get into the cath lab, have an open heart surgery.
Right.
That's very costly.
Yeah.
The point being is, why did you wind up with a heart attack? Did you eat correctly? Right. Did you exercise correctly? If in fact it's genetic, perhaps did you take your medicines? There was obviously a prevention could have possibly prevented all that.
Right.
So you look at public health and prevention, primary care, that kind of thing, but acute care medicine using hospitals is where all the cost is. So the insurance companies, that's where it's funded. Insurance companies don't fund public health.
No.
County health departments do. State funds and federal funds. That's been underfunded.
Because that's going to prevent something in the future, and we're just focused on the now.
You don't see it. I don't see that virus, so I'm not paying attention to it, or that kind of thing. Throughout the world, starting back in London at the Broad Street pump, where epidemiology kind of started, realizing
I never even heard of this story. You're saying in London that they started studying diseases way back when?
Well, and I'm sorry, the physician escapes my mind. He's famous, and that's my fault. But the Broad Street pump is a classic study. People were getting cholera all around this area, and the physician, Chadwick, said, something's going on. Let's start testing. Let's find out. And then he figured out it was drinking water from this pump, but all the sewage was going into the groundwater because they didn't have sewage.
Right.
They had cesspools. And he said, aha, I'm going to take away the pump. And guess what? No one got sick.
Wow.
So again, that focus on prevention has always been public health. It's always been fairly local, and it has been underfunded. Now it's in the forefront.
Right.
You can see what disease can do like this, infectious disease. So will it get more money? It has to get it from somewhere, and it's going to come from other sources. Less maybe going to curative care. I doubt it. More is going to have to come from public funds. And that's what I think we'll see, more public funding of public health departments.
What do you think, Dr. Trinh? You're a big advocate of prevention. Is the public health officer part of this prevention? No, figuring out that the community's getting sick from something, or that a disease has struck the community, and figuring out a plan to deal with this?
Yeah, we can either spend billions of dollars treating Alzheimer's, or we can realize that those who live in areas of higher pollution has a higher rate of Alzheimer's than those who live in areas of lower pollution.
Wow.
And that's a public health issue, right? Dealing with pollution and things of that sort. So you can either tackle it from the front end to address that, or you can treat Alzheimer's patients later on in the back end.
Pay now or pay later. All right. But the public health officer, I just want to narrow this down, because we've had a lot of controversy, obviously, around the public health officers, who I don't think any of us knew even existed. If we did, we certainly didn't know their names. We didn't know there was a Dr. Fauci. We didn't know in Orange County there was a public health care officer, administrator, whatever they call them, a county health official. And when we did discover these people and they came out of the shadows and said, here's what we recommend, we screamed bloody murder. No way. We're not going to shut it down. We're not going to vaccinate everybody. We're not going to do all this stuff. Forget it, buddy. and some of them resigned, and some of them were driven out of office. I'm thinking here of our local in Orange County. When COVID hit, I forgot the woman's name, but she's a doctor, I believe, and I think she was Vietnamese. And then she went to the county and said, "Here's my recommendation. We don't know where this is at, and this is potentially terrible. We should shut this thing down until we get a handle on this." And the very next week, protesters showed up at her house, and she quit. Said, "I don't need the death threats. I'm just telling you what I think is the best solution for now till we get a handle on this." And she resigned. And since then, the county backtracked and said, "Well, okay, we're not sure what to say or what to do." And they've waffled, like so many local entities, in and out of vaccines, in and out of shutdowns, in and out of any direction, because they were afraid of the public's reaction.
Well, and it's understandable. They've not done a very good job of communicating their role in healthcare overall.
No,
and
that's
the power the public health department has, which in fact, they can go in and shut your restaurant down. They can go shut your business down if there's water leakage and rats. Yep. They do have extenuating circumstance types of power. Right. And the power can be to shut down areas of infection. And that's law, that's county law, that's state law. Where the federal government comes in, you start getting into states' rights, and you're seeing those difficulties now, lawsuits against the federal government saying
Florida says you can't impose that mandate down here. Forget it. Yeah.
So there's not a national. There are federal laws, state laws, county laws. Sometimes they don't work well together. I had our county health department leader, Dr. Wilma Wooten, talk to my class, because my focus on my class is just not how to run a health system, an integrated health system, classic Cedars-Sinai health system. I have the CEO lecture to my class. How do you organize and operate a hospital, medical group, clinics, all in one, in delivering the goal of delivering the triple aim, which is a goal of great customer service, great clinical care, and reduce per capita cost. Yes. How do you do that? He goes on and tells about his classic system, but I also bring in public health or county health level systems that in fact integrate public health as well. Now, Cedars-Sinai is not a public health institution. No. It's a private, not-for-profit organization. And it certainly has intersection with public health. But your county health system, like in Los Angeles or in San Bernardino, also not only has a public health department, but they have a county health department, a county health system, a hospital and clinics. So that's an organized system.
The county itself runs hospitals? I didn't know that.
Yeah, sure. LA County certainly has Orange County contracts with private hospitals to take care of county level type patients. But if you look at a classic system like San Bernardino County, and I'm having the leadership of San Bernardino County Health and Public Health be my special guest speaker for my class. Mm-hmm. The fact is that's a system organized to take care of the underserved. And whereas
we're talking about homeless people or people without insurance.
Sure, yes, all those who are disenfranchised may not have health insurance at all. And we have to deliver care in some fashion. Go back to the poor farms.
Yes, right.
Poor people were homeless. They were didn't have food. They were picked up in wagons and taken to the poor farm, which some became county hospitals. So again, you have a couple of different systems in this world. We do have the larger systems of hospitals now coming together to form integrated health systems, which includes physician groups. Remember, physicians were separate.
Yes, right. And I know that out in the desert, I have my parents lived out there, and I inherited a home out in Palm Springs, Palm Desert area.
Sure, you have the Eisenhower system out there, and you have Kennedy, and you have other medical groups, and a lot of them affiliate or were bought by.
So, can I ask another ugly? I'm going to be one of these, ugly people that doesn't like the healthcare system. I'm not sure that's a good idea. I get the cost advantage. I get the integrated records, but it seems like it becomes a monopoly and a pricing monopoly at that. So if you don't like what Eisenhower charges or Kennedy, or I think there's only two choices out in the desert, tough luck. You know, every physician basically group belongs to one of those two hospital groups. And if your insurance doesn't have a good relationship with them, or you don't have insurance at all, that's it. Now, I know it's for profit, but they run it like a profit company. I mean, it's a pricing, they're there to make money. They're not there to serve the poor.
Well, actually, they do. They have requirements for community health benefits. They're not for profit, meaning their profits are plowed back into the community or to the hospital for the betterment of delivery of health care.
But too often, I think they just take, I'll make one little rant. Too often, I think they take that because they have to spend the money. They're technically not for profit. So whatever profit they do make, they have to reinvest. And the idea sounds great, except all they do is either pay their executives exorbitant salaries, in many of our opinions here, or so they plow it back into, you know, raising salaries of administrators and stuff, or they just buy up more physician groups at pretty steep prices here.
I mean, that may some of that may be true, but a large part of it, because I was part of a very large health system, and I understood exactly where the money goes. And also, there's dictates by law as to what constructs public benefit and community benefit. And it has to be reported. And you easily can go to Eisenhower or Kennedy and ask them to show their community benefits and where their money goes. And often it goes not to just salary or buying physician groups. Where it does go often is to betterment of the physical plant, which is another part of why prices go up, because we have to have the latest technology.
Yes, exactly.
Fakes you don't have the newest MRI on the block.
They all do.
But it does go to that. It goes to the physical plant. It goes to community benefit, providing charity care. It's mandated by federal law through Medicare and Medicaid. And if you're going to participate in that, there are certain requirements. So there's charity care. There's reduced care costs. There could be funds going to clinics. So there's a lot going behind the scene there. And the fact of the matter is, when you think about it, medical care does not construct to or fit to the capitalistic mindset. In essence, think about it. If you cut your finger and it's bleeding and you're worried about bleeding to death, are you going to go say, no, see which emergency department has the best cost?
Yeah, and I'm going to walk in there and say this. No, I'm going to leave.
Running right there, and you can say, fix it. Yeah. Are you in midstream going to say, no, doctor, I don't think I want you. I want this other doctor.
Right.
Well, you have that one doctor in front of you. You don't have a choice. Can you say, doctor, it's getting too expensive? You don't really know how much it is.
Right.
Can you stop? Well, no, I got to suture this up, or it's going to go open again.
You're 100% right. And the other, I'll go one step further with that, is because someone else is paying for it, I don't even ask those questions. And
that's absolutely correct. There's no skin in the game.
Yeah, right.
For a lot of people.
Right.
And so that's where it comes down to, and I cover all this in my class. I want you to know that my class isn't just, the steel and the bricks and the mortars. It's about the concept of delivering quality care. And it's really care when it's needed at the right time, at the right place, by the right provider, and by the right sequence in the spectrum of disease. In my concept of my class and how I've always functioned in my career in healthcare was, let's focus on going upstream so that you don't have problems downstream. Let's see where we could save lives and pain and misery, but deliver acute care when needed at the right time, at the right place. And I could say that my focus is also on quality, a value care proposition of capitation and global healthcare under a fixed budget, which gets us away from fee for service, which is often touted as
fee for service. There's the one we were trying to get at. Dr. Trinh, fee for, he sometimes rants about fee for service. He had somebody on last week talking about value-based care and accountable care organizations. And
that's what I teach too.
Okay.
Love it. What percentage of the country is still fee for service?
About 85%. So
serious?
Yeah.
Wow.
Yeah, the predominant, now, not in California, and we're kind of unique here. And we've been in the forefront of the capitated movement from the history of the Cigna health plans, which actually started a capitated movement years
what
ago.
Is a capitated? You say that like we all know what that is. What's a capitated movement?
Capitated, let's go to the gold standard, Kaiser.
Okay.
So Kaiser Healthcare is a true integrated system because it has the insurance component, the hospital component, and the physician component all rolled into one.
Right.
And
so if you buy Kaiser insurance, you go to Kaiser hospitals, Kaiser doctors. It's a completely self-contained system.
Absolutely.
Right.
Right. And so it started back when they started building Hoover Dam, and someone came up to Sidney Garfield and Kaiser and said, can you take care of my people out there in the desert? And he said, yeah, for $25 a month, I'll take care of them.
$25 a month.
I'm going to get a fixed dollar amount of money every month, whether I see you or not.
Right.
Yeah.
But I've got to take care of you. And
whatever it costs, I got to figure it. Yeah. Right. Exactly.
So, and then you buy reinsurance and because it could always go over, and
right.
There's only so much risk an individual or group or hospital can take.
Right.
But there's the rub. The bit larger you are, the larger risk you can take. The larger population of prepaid healthcare capitation that you can take on. Fee-for-service still is the dominant way.
So let's stop for 1 second and explore that a little bit, because I don't think that gets discussed enough. So the Kaiser model, as I understand it, Henry J. Kaiser, this big industrialist around World War II who had steel plants out in Fontana and all these other places,
right.
took this and integrated it into his factories. And so he created his own healthcare system for his own workers, basically. That's
correct. And particularly the Liberty ships being built up in Richmond in the Oakland area. And that's where Kaiser's headquarters is, because that's where it really started. Again, he did help provide care out in the desert, building the Hoover Dam.
So Henry J. Kaiser, this big industrialist, said it's cheaper if I take care of my own people. They'll be healthier. They won't lose work. Right. And it'll be a benefit to working for me, and it'll make sense because I'll get healthier, happier workers and attract better people and all this stuff. So he created an integrated system. Why didn't
the concept even went further, of course, then, because they realized, hey, I've got the hospital, I've got the doctors, I've got the insurance company. I've got to live within the budget. I'm going to charge a premium to the employers besides his own, and I have to be competitive.
Right.
But given that I have a fixed budget, that's what the concept is. What's my incentive?
Right.
To let the patient get sick and then run up millions of dollars in the hospital?
No, I'd lose money that way. Right. Yeah.
Or can I focus on primary care, the primary care physicians, internists, family medicine, pediatrics, and yes, OBGYN, because that's often the primary care for women.
Right.
Yep.
I also throw in psychiatry.
Okay.
Some people don't. I consider that very important in the overall aspect of healthcare.
These are the frontline doctors that face the patients first. Primary care.
And that's primary care. There's a shortage because primary care actually reimburses less than specialty care.
Yeah.
But nevertheless, again, the focus then can be to bring on nurse practitioners, physician assistants, the advanced practice folks who can actually do much of the primary care that a physician can do. So that extends your outreach. Then you focus on prevention, healthy habits, and you get into social determinants if you can. Now, that's a new buzzword, not buzzword.
Social determinants. All right.
Social determinants of health is where, if you really want to look at the primary prevention of health, you come down to what you eat, how you exercise, and other social determinants such as being in a food desert where you don't have adequate access to healthy food.
A food desert. All you're eating is crap. All you're eating is fast food.
And then you go to homelessness, mental health problems, poor sanitation, everything that you think of that really now we're talking about like public health realm
and
social realm. Well, your average physician in a fee-for-service office taking care of the patients who come in to see him, where do they have the money to put into social determinants? That's a social function. As you get larger with integrated health systems who accept more capitation, that is the value-based.
The capitation means a cap. You're only going to get so much for this
dollar
patient.
amount. You've got $400 per patient as a senior patient per month. Now you got to take care of them. As you get into that, where you have this big capitated budget, you can, if you have the right mindset, focus on primary care, and in fact enjoy a surplus of money. And you got that way because you kept the patients healthy into whatever degree. So
who would have thought? What a radical idea. There's a profit in keeping them healthy, not just profit in treating them when they're sick. What a radical idea. Yeah.
So Kaiser, at least Kaiser's Southern Cal, at least maybe $5 million into food for communities.
Really?
That kind of thing. And I don't hold me to the dollar amount.
Yeah, but I didn't know Kaiser did any of that. I thought they're just a healthcare system. They don't go out and help the community.
They're very much involved in the community. Cedars-Sinai Health gives many dollars to the federally qualified clinics that are for poor folks in certain areas of LA. In fact, they joint venture with them to help provide services. In other words, the concept of having a bucket of money, and at the end of the day, because you kept people healthy, not just again, there's a moral benefit of this. There's a moral.
But that's been left out of the whole discussion. It's always been just about money. No,
it's not always about money. Dr. Trinh didn't go in just for the money.
No, I agree that, but the perception of the public and my perception is
money's there.
Yeah.
But these are people who are at the front line, or your surgeon or cardiac. They're doing it for the love of taking care of people. Right. But now, of course, money does enter into it.
Because the federal government mandates you only can spend so much, and so it becomes an assembly line. I crank more patients through. I can only see them for 5 minutes.
Yes.
You know, it does turn into money as a determinant, how much you're getting reimbursed, whether I go into this field or that field. I mean, money plays an inordinate influence. It
is, and it's true in any business, and medicine's a business.
Yeah, medicine's a business, exactly.
And this is why my students and others are trying to learn the business of medicine, because medicine, the healthcare is a business, it's clinical, and it's service, all rolled into one.
Yeah, right.
And they all have to fit together.
So let me ask the question, Dr. Trinh, and this is going to sound like the radical hippie I used to be here. Should medicine be a business, or should it be a public health benefit, a public service, a public right, something else, as we've all sorts of people running around?
How do you define a business? Because even if it's a public health service, those providing those services need to get paid. Right? Is there a cap on the salary because it's public health? Is it how do you define that?
So how do they define it in Europe and other places where they have this more socialist model, this idea that public health is a right, and it's something that's provided every citizen by the government here?
Yeah, so it's run by the government. It's run by the government.
So instead of a business, it's a bureaucracy.
Yes, that's what you know. I mean, if you look at the NHS, right, in England, healthcare is run by the government. Healthcare is run by the government in Canada. Right. So you kind of, it's. So
what's your guest view of all that? Because I hear people say, "Oh my God, we don't want to be Canada, we don't want to be England," and then others say, "Why not?"
Ooh, what do you think, Mr. Kaplan?
Well, I can tell you, after looking closely at NHS recently, the fact that the waiting time for certain issues that you have or problems are 2 years.
Wow.
And the fact that they just put out an article saying that they're going to look at a lot of deaths because of postponed visits to doctors. They, in fact, had to enforce their general practitioners to see patients. They were refusing to see them in person. And you get into it, and they were unionized. So you get into a bit of difficulty. The fact is, there's no infinite amount of money. And if you're into, let's say, government funded, you can tax everybody 100%. And I'm sorry, I think it's all going to go to medical care. The whole idea here is that what we're living with in America is predominantly was fee for service, now trying to move to a more capitated global risk model that really takes into a focus all aspects of healthcare, from primary care to chronic care to acute care to chronic care, and deliver it in a very business-like way that's efficient. Business is not a bad word.
Right.
You run your radio station. Again, I don't know what you do.
Yes, I do. Right. I'm a capitalist.
Like a business that is, you're efficient, you're effective, you measure that, you give good service, and you measure that. And
we do it as I do, like in a weird way, like Dr. Trinh and you guys. I feel like this is a public calling, a public service to tell these stories and everything. So I need to get paid, and I want to make money at it, and I want to be profitable. But that wasn't my first motivation. Let's see what's the best way to make money? Oh, I'm going to open a radio. So I'm going to be a doctor. Oh yeah, that's the best way to make money here. Right.
No, we have to recognize that physicians are well paid in this country. The average is for primary care about $250,000 nationally, but more here in California, and a year. And then specialists $700,000 for orthopedists and cardiac surgeon. But they take risks and they go to school longer, and there's a lot of reasons why. There's still a lot of debate about specialists being paid too much, primary care not being paid enough, and how do you affect that change? I think very difficult. But again, it's still a very well-paid profession. And I can tell you that we make more money in this country, probably about double any other country as far as physician salary.
So here's the other one, Dr. Trinh, and your guest here that I hear all the time. And it's something like this, that when you measure health outcomes in around the world, that we in the United States tend to pay more than other countries and get less in return.
Absolutely. And it's driven by fee for service. We do not pay driven on health outcome. We're paid based on procedures. The more procedures we do, the more we get paid despite the outcome, which is why this system is so convoluted. Which is why Mr. Kaplan teaches these courses.
And does the Kaiser model, the capitated, where you put a cap on this, and they fully integrated so they can have some cost savings and all this kind of stuff here, type of stuff that happens as you accumulate, what do they call it, vertical integration. Everything's integrated together, from the doctor to the hospital to the testing facilities to the insurance. Record keeping, all that stuff is within, so they get cost savings and whatnot, and they squeeze more out of it. Is that model, which is not a fee for service model, it's a capitate, you get so much and you got to take care of them no matter what happens. Is that model more efficient, effective, and dare I say a bigger bang for your buck?
Well, I'm going to say really quick that when I teach my course, and when we talk about this at even our annual conference coming up of capitated type medical groups and health systems, the fact is that Kaiser's often used as a gold standard.
Really? Okay.
Because and other systems are trying to emulate it, and they buy insurance and they don't do well at it. There are very few, in fact, health systems that have their own insurance plan affiliated. The Marshfield Clinic actually does in Wisconsin, and does a good job. And that's a physician-owned system, not a hospital-owned system. Again, the fact is that Kaiser, being so integrated, has all these controls in place, and their motivation really oriented to primary care. Other systems, I hate to say it, it's still the way it is, dependent on the fee for service. And the reason why we have a difficulty here is this, that Medicare pays less than commercial insurances. So where hospitals are the big driver of healthcare and costs, the fact is that commercial insurance pays like 120% more on the dollar than Medicare. That if you ask hospital administrators right now, if they had to just accept Medicare rates across the board, some would be closing.
Really, and I see more and more physician groups. My late father was, his doctor joined one, and they just announced, we're not taking Medicare anymore. So you can pay us a fee, and you can see us as often as you want, but don't give us your Medicare because it's too expensive, doesn't pay enough, and we don't want it.
That can happen when there's a lot of competition and the doctors are in a general well-off area, and they can pick and choose. That doesn't happen always across the board.
Right.
But frankly, I've managed many medical groups through LA and Orange County, and we always had Medicare. We didn't have Medicaid. That's because that pays
even less.
Half of Medicare. I mean, it doesn't pay well at all. But and the administration of Medicaid's really tough to deal with.
And let me give you one classic example, then I'll bring Dr. Trinh in again here. So my late aunt had very little money, and she lived on $2,000 a month, which hard to believe. But she lived out in the desert. She rented a little place, and she eked by on, I think she had $2,500 a month. Her total Medicare, Social Security, and her tiny little pension and everything, that was what her whole budget was. And so when she got very ill in her 90s and needed to move into an assisted living, she didn't have so little money. She had like $10,000, which was too much to qualify for Medicaid. But even had she gotten rid of that money and we spent it down, because you can't just give it away, there was no Medicaid nursing home, whatever you want to call assisted living, anywhere within 100 miles, because they said, you know how little they pay? We don't want that money.
So that is a problem that is on a national level. So now, we're focused on a whole other show.
Yes.
Dr. Trinh could do. I'd be glad to join. The fact is that we have an aging population.
Yes.
We have a need for more memory care.
Yes.
Skilled nursing, other congregate living. These are various levels, assisted living.
Group homes.
We're short of. It costs a lot of money to do all that, and the question is that where's that money going to come from? And
let's do that another day,
because underfunded area.
Yes,
but here in Carlsbad, I've got 33, I think coming up 37 of those kind of facilities, and I worked with them as a volunteer for the city to make sure that they got masks and gowns during the COVID epidemic. I'm a community emergency response team member here in the city of Carlsbad. The fact is that there are more opening here because there are more adults who need this care who can afford it. They're all private.
Right. And that's what we did several shows in this where we brought big groups that come in to have these assisted living facilities and stuff. And they would all, offline, they all told me the same thing. Your aunt is screwed. I'm sorry to say it. Nobody wants her business. There's no money for her. We all chasing the top 10% that can afford $10,000 a month, $6,000 a month, $8,000.
Let me comment on some of this, because also Kaiser has developed what's called a hospital at home.
Yeah.
And a lot of these health systems, and when I say integrated, they've also brought in home care, hospice, and other kind of home-related services, recognizing, and I recognize this when I was running my medical groups, if we can keep the patient home in an environment they know, and it's safe for them to do so, if we can deliver the care there, that's going to be $100 a day versus,
and they'll be happier. They'll be happier, and it'll cost
a day
less.
Versus a hospital at $2,000. In other words, the idea is if we can deliver care at the home, there's adequate caregiving, respite care, and all that. That makes economic sense, but even more so, it's better for the patient because they're familiar with their environment.
They're happy.
So those are being tested now.
Well, we should, Dr. Trinh, put that on the priority list, because we need to talk. Because I think when I went through, I'm an only child, so I got to watch my mother pass away, my father pass away, and then her sister, who never got married, pass away. I went through this 3 times, took care of that whole journey from,
I understand.
They entered the system until they died. And I was flabbergasted and angered and shocked at how little prepared we all are for. The good news is we're going to live to be 90. The bad news is we're going to live to be 90. Who's going to pay for this? Who's going to take care of us?
That's correct.
So I'd love to do a show on that someday, but let's get back to because we only got a few minutes left here. I'm still wrapping my head around integrated healthcare systems. Is it just the Kaiser model where it's a vertical integration where they do the hospital and the insurance and the physicians and the where they test and do all the other stuff, the labs and everything else, or is it more integrating that system into the public system?
No, I mean, when we look at integrated health systems, let's say here in Orange County, I was part of the Memorial Healthcare System.
Right, that's what Dr. Trin's part of.
Considered integrated. It has a small insurance component in the Long Beach area, but more importantly, it has a physician group that's loyal to it under its umbrella. It's a very complicated structure in the state of California on these foundation models. I created one of the first foundation models in Orange County called St. Jude. It was called St. Jude Heritage. Right. It's Providence Heritage Medical Group now with St. Jude. What I'm saying is there are various classical systems, Providence, Hoag, Memorial Care. I'm using Orange County because that's where you're located, and I know it very well, and help develop those systems or work with those systems. They're integrated because they realize if they can have the physicians as part of the health system or the hospital, that loyalty there is that's going to drive the business to the hospital. With more business, they can do more things.
Right.
They can deliver things more efficiently. They can afford to have a quality department that looks at patient flow and we look at how do we have patient flow streams and be more efficient and provide and measure the care we're giving and satisfaction. That's what you primarily have. You don't have an organized public health system in Orange County.
So, Dr. Trin, you've been quiet, observing all this as I ask my questions. I'm still trying to wrap my head around. It's a very, very complex topic. Yes. Whether we're talking about public health, what's the government's role in preventing diseases and looking at the general water, infection, safety issues. That's one issue. And then within medicine itself, do we create these conglomerates? Maybe that's an ugly word, but these giant systems where it's all integrated together. They do it all. One shop does it all. Yeah. Which sounds efficient, but then sounds like a bureaucracy, sounds like a monopoly, sounds like other bad possibilities as well. I don't know. I'm trying to wrap my head around this.
There's good and there's bad to having a conglomerate.
Right.
The good, I mean, the bad, the fear is this a monopoly,
yes,
right?
Right?
There's only, 2 providers throughout Orange County, right? So in Orange County, you have, the Hoag system,
or
you have
Kaiser or something. Yeah, right.
Kaiser, and you have like Memorial Care, right? Yeah, so you have a few. So there's not a lot of choices. So that's not necessarily good in a free market.
Right.
But the reason these are conglomerates is based on efficiency. It used to be that I can see what's going on in my medical office, but if my patient gets admitted to the hospital, I have no clue what's going on.
Yes, nor are you allowed to go in. Maybe you're not even an admitted doctor.
I don't have privileges. I can't go in. I have no clue what's going on. I can't look up the medical record. Now I can because of the conglomerate.
Right. And now that makes so much sense. Yeah.
Yeah, because everything is now continuous, right? From the hospital to the outpatient, you can connect because of the conglomerate.
When my late father was dying, and I took him in several times into Eisenhower, which is generally a good hospital. We're always pleased with the service out there. But having said that, his cancer doctor, I'd call him up and ask him something, the doctor, and he'd say, "What did they say?" I say, "What do you mean, what did they say?" "Well, ask the doctor this, find out this." And I'm like, what do you want me to go ask. What do I know about it? You go ask. Don't you guys talk? No, we don't talk. I can't go in there, and they don't tell me what's happening.
So I belong to Scripps Health System.
Okay.
I moved my care down here because I live in Carlsbad. My wife and I belong to Scripps. I happen to know the CEO. And
that helps.
I happen to know a lot of CEOs throughout Southern California because I have them as guest speakers as well. But I guess the point being is down in San Diego, we've got Sharp Health System, which is considered very good. Mm-hmm. We have the Scripps Health System. We have Kaiser, and Kaiser is growing like crazy. And they just built a new hospital, and they were building a new hospital in San Marcos. And then we have the UC San Diego Health System. So that's a whole health system I didn't mention because you have in Orange County UCI.
Yeah, that I didn't. We're at the University of California Beale Applied Innovation Center here at UCI. We're in my UCI cap, so we got to.
UCI is going to build $1 billion new campus,
right?
Medical campus. So again, UC San Diego down here has got ambulatory care clinics, outreach, home health. So you have all these health systems. You have a few other health hospitals with some kind of a system, Palomar, Tri-City, Alvarado, but the big ones are down here. So I joined the big system. Why? Wherever I go in Scripps, they've got that record, the Epic.
Yes.
Epic is the largest electronic record system in the nation. It's one of the best, I think. I helped implement it in memorial care. Point being, that I can go to any of my Scripps doctors and they know exactly what was done to me that day, a week ago, by any of the doctors in the system. So I've got quality orientation here. They know what was done. They don't order another drug or another lab test that's not needed because it's been done.
Right.
That is not what happens when you're not in an organized health system or have access to that kind of data. And that's another driving reason why we see these integrated health systems. It's also integration of information.
We got to do more of this, and I'd like you guys to help me break down. If we did another show or two, aside from the issue of aging, which I think is the overlooked time bomb that's ready to blow up here.
Big important topic.
But take that one aside. That's one we should definitely tackle here. But in this idea of rethinking medicine, and moving from a pay-per-service, which is still the predominant model, to maybe a capitated, integrated, you're buying into monopoly, you're buying into, not monopoly, a conglomerate, you're buying into some big integrated thing here. Or other, we didn't talk about accountable care organizations or other sorts of ideas. That, all these have buzzwords, all of them have things, but what would the next topic be? What, if I did this in sequence, if I'm trying to educate the public, what's the next topic?
The next topic is how to bring healthcare into the metaverse.
Well, that may be. You're laughing, but that may be the future where we're going to, my little avatar is going to talk to your little avatar.
I just need to buy some land first in the metaverse.
You're laughing, but I just read an article about people buying land in the metaverse.
It's going for millions. It's going for thousands. Yeah, so well, I need a plot of land, and then we'll do something.
We'll build a virtual hospital with virtual doctors that you'll virtually visit, and somehow this will help you in the real universe here.
And then we can officially do the first digital exam.
Yeah, you love
that. I like that.
So,
Can we do virtual surgeries? And so they virtually took care of me, but it doesn't really help take care of me. But
we can do robotic surgery from a distance.
Yeah. I'm serious. So what, Professor, what would you teach this? How do you teach us? How do we break this down? I'm still confused. This sea of ideas and this confusing models and all compiled together. I'm trying to find a simple way to explain this to the public, where we're at and where we should go, because we don't know.
Well, what's topmost on the public mind is cost.
Yeah.
I think and I have my patented 24 reasons for the cost of healthcare.
Okay.
Decrease. And I actually throw that in there. That's probably on everybody's mind. And I think we have to delve into the cost of healthcare, who pays, how it's paid, why it's different than selling widgets,
yes,
or going to the grocery store.
I agree, because I'll tell you, one of the things it resembles to me, maybe this is a bad analogy, but it's sort of like airline seats. Everybody sitting on the airline paid a different price for that seat.
Right.
We're all sitting in the same row, but you bought it a long time ago, and you got some points, and you didn't pay anything,
Right.
and somebody else gave you a deal, and you had some special arrangements, so you get special pricing, and I don't, and I pay full price. And everybody everybody's on the same plane, and we're all paying different prices. That's ridiculous.
Yeah, yeah. Well, the other thing, but I'm going to point this out. Medical, if anything's personal, the most personal part of us is medical care.
Right.
It's personal. And your needs are different than my needs. And what needs to be done for you is different than me. And so we got to recognize that it's not one size fits all. It truly is my relationship to my doctor, my provider, and my care and my needs. And again, how do you value that? How do you then ultimately pay for that?
And as the Supreme Court famously said in all these cases where they were trying to people were trying to challenge the Affordable Care Act, and they went and I'm paraphrasing, but they basically said in the last go around, I think it was Justice Roberts that said this, that healthcare is not like a typical, as you pointed out before, a typical product that you sell. I can't, in the middle of the surgery, I can't say how much that costs. No, doc, I'm going down the street. I'm not paying that.
Doesn't happen.
No.
Doesn't happen.
Yeah.
Well, I'd like to, turn this back to you all, Dr. Trinh and Paul, and I'm available to help, to participate.
Let's have that ugly discussion, Dr. Trinh, about money. Who pays? How do we pay? When do we pay? What do we pay? Because I think that will uncover some of these other models and ideas and problems in the system.
I want to continue this chat again. We need a part 2, Mr. Avram. We need a part 2. Let's do part 2 after the new year sometime.
I would love to do that. We'll talk. Certainly, we want to talk about getting you, Dr. Trinh, down to the Mercy, how we can work on that.
Yes.
And Paul, if we wanted another tour of the Midway.
Oh, yeah.
Or any of that, because we can also help, I'd love it just personally, but maybe we can help tell that story too. Maybe there's some way we could tape that or
I believe our CEO of the Midway Museum would love to tell that story.
Let's do it.
We call him Mac. He's a 2-star admiral that retired and runs our museum. There are others who could speak.
Because we have other shows. We do this kind of OC Spotlight. It's kind of us roving reporters talking about things in Southern California, not just Orange County, that we want to spotlight. We want to put a focus on. And it usually doesn't fit into one of our typical business shows on branding or sales, or we do mostly business shows on the channel here.
Oh, I didn't know that.
Yeah, we do about 20 different business shows. This OC Talk Radio is truly an online radio station. It's sort of like live podcasting. We stream them live and then we turn them into podcasts. Dr. Trinh has
do something on the Midway, and
yeah,
there are stories of the Midway.
Would love to hear.
Dr. Trinh can really talk about something that we just did recently, and there is besides the seeing of the ship, learning the history, there's very human, touching stories.
That's what we're always looking for, the real story. We're not just looking for the numbers. Even though I want to do a show about numbers, we really want to find the human stories that put this in perspective. All right, well, let's wrap it up. Take us out, Dr. Trinh, and then hang on, and we'll schedule that after we go off the air here.
Should I hang on?
Yes, hang on for a second, Professor.
I will be glad to do that.
Okay, go ahead,
All
Dr.
right.
Trinh.
By the way, we have a bunch of comments on Facebook.
Oh, tons. You were blowing it up.
Which we'll address another time. But yes, it's great having you here, Avram. Part 2 is needed. And let's do a show on the Midway.
I think that'd be great. I would work on that with our media.
Yeah.
I'm a volunteer, so I'd work with administration on that.
Okay.
That's great. Let's do a show on the Midway, and we'll do that.
All right.
Thanks so much, guys. Learned a lot today about health and public health and integrative health. And now moving on to the Midway next.
Okay, moving on to the Midway. All right. I'm halfway between here and there. All right, thanks, guys. Stick around after the line, and we'll work the rest of this. But for the rest of you, we're going to end it today here. Thanks for joining us on the only place we try and delve into all the issues that deal with healthcare. From start to finish, from soup to nuts, it's Health Talks with Dr. Trinh, right here in Orange County's only community radio station, octalkradio.net. Streaming live from the University of California, Irvine's Beale Applied Innovation Center.